So without further ado, we're going to jump into this session on how best to help rural hospitals and communities thrive. We're going to kick it over to John Bartholomew, the Chief Financial Officer at HCBUF. John, take her away.
Thank you, DJ, and good morning. Welcome to the 1035 panel, Helping Rural Hospitals and Communities Thrive. I am John Bartholomew, the Chief Financial Officer at the Department of Healthcare Policy and Financing. I'll be moderating for today's panelists, and I'm pleased to be joined by 4 experts in their fields. We have Michelle Mills, the CEO of the Colorado Rural Health Center, the nonprofit state office of rural health and Rural Health Association. Established 30 years ago, representing over 150 healthcare providers and facilities in rural and frontier Colorado. I'm also joined by Carrie Pykoch, Director of the Governor's Office of eHealth Innovation, who are promoting the expanded use of health IT throughout Colorado. We also have Nancy Dolson, Director of the Special Financing Division at Healthcare Policy and Financing. She's the department lead on the Hospital Transformation Program and the Chase Enterprise, as well as 15 other programs. And Will Cook, President and CEO of Vail Health, an independent nonprofit integrated healthcare system located in Eagle County. Many of you know that HCBUF has been working diligently to understand how our healthcare dollars are spent, and hospitals comprise the largest percent of the healthcare spend. We have created many tools and reports that have created insights into hospitals' cost and price and profit. Today, we'll be focusing on hospitals located in rural and frontier Colorado who face economic challenges in meeting the community's growing needs in healthcare. In this discussion, we'll learn about the challenges these facilities face and hear from experts on what initiatives are taking place now and what is still needed. Many of these rural inpatient facilities have seen their business model shift to predominantly outpatient care, with Medicare and Medicaid being the dominant payer, coupled with an aging population. These facilities face considerable costs complying with various federal and state rules and regulations with flat or negative margins. This hinders their ability to keep up with participating in innovative new payment models or capital changes needed to meet today and tomorrow's community's needs. So I'm going to turn to Michelle Mills for our first question. Michelle, tell us what some of the biggest challenges facing rural hospitals right now are, and what are the top needs of those hospitals?
Hi, John. Thanks so much for that question. Really appreciate it. Some of the biggest challenges are rural sustainability and really to be able to ensure that access to care in our rural communities. So rural hospitals are one of the top 3 employers in our rural communities, and we are the infrastructure in that community, and that really drives the local economy there. If a rural hospital closes, the town tends to die, and you don't only lose the largest employer, but you lose the small businesses. And without healthcare, really the ability to attract new businesses there. We have a growing, aging population. Nearly 20% of our population is 65 plus in our rural and frontier counties. We have a higher rate of chronic disease, and I know that you guys know that 7 out of the 10 deaths in Colorado can be attributed to 4 diseases, and that's heart disease, stroke, cancer, and diabetes. And all of those exist really in our rural communities. We have higher rates of public and private insurance, and so some of our rural and frontier counties have nearly 90% Medicare and Medicaid. So it's really difficult to innovate when you have that type of a payer mix. The costs continue to rise. As I know you know, a rural hospital can spend upwards of $1 million for a new electronic medical record, and that needs to happen to really meet today's regulations, not to mention that care coordination and patient safety. And it typically doesn't include things like an analytics platform. That doesn't include connection to the health information exchange connection, and then the ongoing costs that really occur for having IT expertise and technical assistance support that's really needed to make sure all of those things are working. Financial viability really is a key concern for us. With 18 rural hospitals operating in the red and nearly 70% of their revenue coming from the rural health clinic that's associated with them, it's imperative that we figure out this. With with and when COVID hit, not only were services shut down in the hospitals and the clinics, but they also haven't returned to those pre-COVID levels. So remember, I said that 70% of the revenue comes from the rural health clinic associated with the rural hospital. You know, they're averaging anywhere between 60 and 80% of their current volumes as compared to pre-COVID. So that means they're continuing to lose money. So I know the situation is probably much dire than the 18 rural hospitals that were previously operating in the red. So some of the needs that we have and need is that we need to remember that in rural, our hospitals and our clinics are the infrastructure. And so we need state and federal stimulus funds to help accelerate those efforts in rural. And we need this funding now. So the situation's dire. You know, when the funding stopped and we had the inability to be able to see those patients and we received the CARES Act funding, that was great. But those were loans and those have to be paid back. And so once people have to start paying those back, the situation's going to look worse. We've been lucky in Colorado that we haven't seen any rural hospitals close in many years, and I think that's partly due to the Medicaid expansion here in Colorado. But really, without that further stimulus funding, we're not going to be able to innovate, and we really risk the ability to be able to remain open and ensure that there's that access to care in our rural communities. We need funding to build the systems that are sustainable to meet our community needs, such as greater access to specialty services that allow our patients to remain in their local community versus having to drive 2 or more hours to seek that care. We need funding to support things like telehealth and equipment and the building out of broadband. We need funding to support the connection to the health information exchange, and we need funding to support the analytics platform. So as you know, many entities require rural hospitals, actually all hospitals and clinics to report. And without having a proper analytics format that not only works at the local level, but works to gather all of that information for all rural hospitals, it's very difficult to make statements about what rural hospitals are doing and the type of excellent care that they're providing. We need a payment model that supports our infrastructure and our community needs, including preventative care, social determinants of health, and innovation. That's so important now. We need relaxation in regulations to help make sure that our systems are efficient, including the ability to collaborate with other rural partners to help ensure that the needs of our local communities are being tailored to those unique community needs. And remember that rural hospitals and rural health clinics were created to provide access to care. And we are, again, the infrastructure in those rural communities. So we really need support and funding and assistance to be able to maintain that infrastructure.
Thank you. A lot of needs, but I think we have some of the right people on the phone to talk more about that. Some of those needs, Carrie, I kind of heard maybe fall into your swim lane. So tell us, how does the Office of eHealth Innovation and the eHealth Commission help rural communities?
Thanks, Jonathan. So let me get started by saying that we are doing a lot of work in this area, but there's still a need for federal funding, flexible federal funding and policy reform. But I'll highlight what we're doing here locally. So OHI and the eHealth Commission are working on key strategies, projects, and funding to support rural hospitals and communities as part of our health IT roadmap efforts to advance state health priorities. Our first initiative is focused on telemedicine. We are currently right now funding 34 individual telemedicine projects across the state. This started as a response to COVID and continues through early spring. This includes projects with Colorado Eastern Plains Healthcare Consortium, Access Health in Southwest Colorado, Ute Mountain Emergency Medical Services, and several other providers throughout the state and rural communities. We're also working with state agencies as part of the Behavioral Health Task Force to advance telebehavioral health. Since last March, we've seen 600% increase in use of telemedicine for telebehavioral health purposes. But we still have a lot more to learn in the space to ensure safe, affordable, clinically appropriate use of this technology, especially for those in crisis. To help refine how we use telemedicine, OHI is partnering with Prime Health and facilitating regional learning collaboratives with stakeholders to share insights and challenges related to this technology. Everything from that to broadband. The next phase will include collaboratives with state and community leaders on the Western Slope, Eastern Plains, Denver metro areas, but I want to stress all rural hospitals and communities are welcome to participate, so stay tuned for that information. Our second initiative is focused on health information exchanges. They play an essential role in our state's public health response, cost reduction, quality improvements, and health equity efforts, as highlighted by our Lieutenant Governor this morning. Our rural providers and communities need access to critical data to advance this work, and our HAEs are the, I refer to them as the pipes across siloed systems, not only in the community, but across state systems to make this happen. But we recognize cost is a barrier. We also recognize that not all providers can afford the fancy electronic health records known as Epic, Cerner, Meditech. I can't believe I'm calling Meditech fancy. But I want to stress there is some funding available for rural providers and hospitals to connect. This includes remaining high-tech funds that HCPF and our office have made available more so ever this last year. And then Nancy's going to talk about hospital transformation dollars that can be leveraged among all the other things that you're doing to pay for upgrades, enhancements, and feeds. But want to stress that tip of the iceberg for funding for these hospitals. We are also launching a rural connectivity project with Colorado Rural Health Center this year. I'm pretty excited about to provide technical assistance, assess how are those health information exchange? Are they connected or not? What's your electronic health record and broadband capabilities, as well as provide analytic tools and supports as mentioned by Tom Leahy and Kim earlier for the prescriber tool, COVID dashboard tools, and much more. And last but not least, I'll quickly highlight, which is on everyone's minds, we're in these square boxes. To connect to this, you need broadband, cellular connectivity. The governor wasn't waiting on the federal government for releasing stimulus funding, but there is funding coming at the federal level. However, both the local providers as well as nationally, we have to compete for those dollars. There's no state block grants, but for the Governor Polis, there's a stimulus package that he released, and it includes $160 million for broadband. $20 million was approved in the special session to support education, online education through hotspots and subsidies for students and teachers. And the remaining $140 million being requested through a supplemental budget request is for the deployment of middle and last mile connections and devices to support education, telemedicine, and economic recovery. So just a few ways, but again, stressing the need for additional policy reform and federal funding.
Thank you, Carrie. And you mentioned OHI. I just want to point out that's the Office of eHealth Innovation. And I mentioned HCPF, and we've all mentioned HCPF. HCPF is the Department of Healthcare Policy and Financing. Just get our acronyms straight. I sometimes hear that we use them too much. But Director Dolson's working on a lot of projects at the state level. Nancy, could you tell us how the Hospital Transformation Program helps with strategic planning, analytics, capital, and other needs of rural hospitals?
Absolutely. Thanks, John, for the question, and good morning, everyone. The department's really pleased as part of the Hospital Transformation Program to offer $12 million a year for each of 5 years in a rural support fund that'll be directed to our rural and critical access hospitals with the lowest patient revenue or cash reserves in the state. In total, there are 23 hospitals throughout the state that will be eligible for these funds. There are three main areas where these rural hospitals can use the funding to transform their service offerings and affordability capabilities, which we hope will drive financial sustainability for these hospitals. First of which is improving or increasing technical capacity. As Michelle spoke to, really enhancing patient care occurs when providers have access to a complete electronic health record and a complete picture of prior claims as well. So investing in improving or increasing technical capacities will help hospitals improve patient outcomes, reduce costs, and improve the overall quality of the health delivery system in Colorado. Specific examples of where this funds can be used to increase technical capacity include improved data analytics, actuarial services, financial modeling capabilities, as well as supporting their electronic health records and health information exchange support in line and in support of the funding that the Office of eHealth Innovation will be providing that Carrie mentioned. The second area that hospitals can use these rural support funds to help is for transformation capital to operationalize a strategic plan. We know engaging with community organizations and other downstream providers will enhance the ability of the hospital to streamline their service delivery and make strategic investments in areas in which they can spur innovation within their communities. So here we're really talking about supporting building centers of excellence capacity in the state in our rural areas. Some specific examples of transformation capital uses under this area are to enhance or fund shared clinical resources, such as for behavioral health or substance use disorder treatment, converting inpatient beds to ambulatory health suites or to substance use disorder beds, if that's the need, and in general, building capacity for the behavioral health continuum of care. Finally, hospitals can use this rural support fund to invest in value-based organizational improvements. Organizational readiness for value-based improvements is dependent, as we know, on well-qualified and well-trained personnel, and this funding can support those activities. I do want to recognize while $12 million a year is significant, and it's about $500,000 a year per hospital, it's really not enough to fund all these efforts. So we need to continue to partner with OHI, with rural hospitals, with the federal funding as well that's available. And we need additional support, as we know, for increasing technical capacity, ongoing electronic health record, health information exchange, and analytic capacity. It'd really be great if there is a bigger tranche of stimulus money that's available in advance of this rural support fund. That would greatly enhance and accelerate the process of getting these hospitals where they need to be to meet the community needs of the 21st century. And as healthcare is in the midst of significant transformation here at the Department of Healthcare Policy and Financing, we want to help facilitate the support for our rural hospital partners. Thanks, John.
Thank you, Nancy. Very insightful and helpful. I've been hearing about Eagle County's healthcare needs for years, and I was able to visit Vail Health since Mr. Cook has been there in a few short years. I'm so impressed with what he's done. So, Will, could you tell us how Vail Health has identified and is addressing the needs of your community? And I know one of those needs is affordability of healthcare.
You bet, John, and thank you for the opportunity to speak today. Unfortunately, there were a lot of signs about the problem in our mountain communities relative to affordability. Eagle County, despite having one of the healthiest populations in the state, had one of the highest uninsured rates at 16%. And that's concerning. And when you look a little deeper and you see that the primary cause for personal bankruptcy is related to an inability to pay a large medical bill, and people were just choosing not to get insurance because they couldn't afford it, and then inevitably not only creating problems financially for themselves, but not managing a disease that they may have. It's just not the right thing to have happen in a community like ours, anywhere for that matter. And so immediately when I got there, we began to work with local commercial insurance carriers, in particular Anthem, on ways that we could lower our rates, as well as look at utilization challenges and where were people using healthcare and was it effective. We worked with a lot of large self-insured employers to lower their rates as well. We were embracing a lot of what was coming out of the state from the governor's office and Kim and others. Whether or not that was reinsurance on the self-insured side of things or other initiatives that came out. We also worked with our local Chamber of Commerce, which in the Eagle River Valley is the Vail Valley Partnership, to partner with them on ways that we could reach out to a lot of our small businesses and help them with these challenges. Where we live, 90% of the organizations have 20 employees or less, and they just can't afford to offer insurance in many instances. And that's a real competitive disadvantage. So we began working with them on ways that we could address that problem. We created something called the Mountain Healthcare Coalition, where we're looking at ways that we can reduce not only premiums, but out-of-pocket costs. Because as you know, it's not just what you have deducted from your paycheck every couple of weeks, it's also what you might pay in a deductible or in co-insurance, and that can be the thing that breaks the budget. So all of this is what we've done to try and enhance access to more affordable care. We've got a lot of work still to do.
Awesome. Very impressive. Now, tell us kind of looking forward about some of the long-term community investment strategies you're looking at.
You bet. Vail has been very fortunate. We live in a mountain resort town, and we're not always in the same situation as some of our rural brethren that are not as fortunate to have tourism and things that come to our valley. And while we focused on medical destination with orthopedics, which gave us some margins, we really wanted to do something to give back to this community in addition to enhancing access to more affordable care. And the number one thing that was standing out was behavioral health. There's a bit of a paradise paradox that happens in these mountain communities. I think it has a lot to do with the fact that many people move here without their family and that support system that it provides. And when you marry that to the fact that there was such a dearth of behavioral health providers, a lot of people's needs were going unmet. And this does include things like the seasonality effect and just how expensive it is to live in the mountains. Beyond healthcare, housing is very expensive, daycare is hard. So we actually had, on a per capita basis, some of the worst suicide rates. Just about every category of behavioral health was off the charts, worse than most metropolitan areas. So what really started was a community-wide effort. It included providers, paramedics, law enforcement, education, just about every social service agency you can think of. But I would say the most important first step is it has to be a community-driven, grassroots, ground-up initiative, whether or not it ends up in behavioral health or something else, because people then become much more vested in it. And when it became clear that we needed an organization to serve as the backbone to coordinate all of these initiatives and to fund them, it just made sense for Vail Health to do it. We're the independent local healthcare system, and we wanted to step forward. So our board, which was incredibly supportive of this, committed $60 million over 10 years, plus agreed to have our foundation raise another $100 million. And we put together a bunch of initiatives to begin to address the problem. Number one was adding 50 behavioral health providers to our valley, because again, if you don't have access to providers, whether or not it's behavioral health or cardiology or endocrine or some of the other things you've heard some of my colleagues speak about today, people won't drive 2+ hours to get the care that they need, and then they won't have their needs met. So I'm proud to say that 18 months into it, we've added 30 of the 50 providers, and that's made a huge difference. We've also taken those providers, integrated them into primary care. We've integrated them into the schools and into our jail. Another initiative that we're working on is to build a new facility that will be 1 part inpatient behavioral health beds and 1 part intensive outpatient, 1 part respite. The challenge is that, even when you get upstream to the problem and help people address the issue, they still from time to time have acute needs. And before, they would go to Denver or to Grand Junction, great places, wonderful care, but then they would come back to the valley and not have a behavioral health provider to hand them off to. And that would create a vicious cycle. And by having the care locally, then the family members in the support system who does live here can be there with them, as opposed to having to take off work and drive to Denver or go to Grand Junction. So that's another big initiative we're working on. Another one is we worked with the Hope Center to create a crisis response that sends behavioral health providers out into the field with paramedics. And by doing this, we reduced transfers to our emergency department by 75%. And when you think about an ED visit costing on average about $25,000, especially for someone who doesn't have insurance, that could just exacerbate a behavioral health problem. So we've done a lot of exciting things. There's more that's happening, but I want to be mindful of the time and just tell you that the key here is, as large nonprofit organizations or even small ones, you're the backbone of the community, as you've heard today. And if you do have the means, really working, whether or not it's through the Hospital Transformation Project or the Community Health Needs Assessment, really pick one thing that's going to be most impactful, work with the community, commit the resources, whether or not it's subject matter expertise and or financial resources, and try to move the needle.
Thank you. It's very impressive. I have a technological question. So Carrie, I'm going to come back to you on what tools are helping automate and accelerate drug prescriptions and the social determinants of health screenings to reduce costs.
Absolutely. And as we heard from our last panelist, accelerating and moving the needle, we need tools. So first and foremost, would say, one, connect to your health information exchange. There's some advances within that, and that connects you to the statewide pipeline for tools. As you may have heard earlier this morning, Tom Leahy highlighted that the state is launching a prescriber tool with OHI, the Office of Health Innovation. I'll use that acronym a couple times, and HCPF, you're familiar with that one. The first phase includes automating clinical decision support to the point of care for understanding if your patient's at risk for opioid abuse within the provider's workflow. This module is being provided by OpiSafe and is available to Medicaid providers. HCPF is providing a limited number of user licenses free of charge this year. So would encourage you to reach out to HCPF to get signed up for that. There's an online request form and they can go through those details. The next couple phases, next one rolls out this summer, includes real-time benefit checking of covered therapeutic alternatives, patient co-pays, drug costs for Medicaid, prior authorizations, electronic prescribing, and electronic authorization. So some neat advances with that. And then the later phases just prescribe social programs such as state food programs and other human services. OHI and HCPF have been really working to figure out how we connect the pipes there, and have been working with our health information exchanges to include and plan out that infrastructure further. We've completed that first phase and are launching our second phase this year. And I'm looking forward to further aligning those efforts and leveraging partners like 211 to be able to do closed loop referrals for housing and food programs. To make that next phase happen, I just want to stress the importance again of aligning federal information sharing policies when it relates to social determinants of health. We can't proactively increase access to programs here locally if outdated rules prevent us to do so, even with patient or client consents. Rural providers would also benefit from additional funding to upgrade electronic health records or actually purchase something. They may have never been part of the meaningful use program because it wasn't of value to them, and it's not affordable. So I just want to stress that, as well as having access to population health analytics and reporting capabilities. High-tech funding is available. There is some funding through Medicaid enterprise funding through CMS, but they don't typically cover electronic health records on ongoing fees. There is some funding, like I mentioned earlier, through HTP, the Hospital Transformation Program, but there's still a lot of work and energy there. But reach out to HCPF for the prescriber tool. It's available and it's a step in the right direction.
Thank you, Carrie. So heard a lot of things that Will has been doing, and some of them are very important around community engagement, but some of the things Will mentioned require some capital, and not every rural facility has capital. So, and it kind of addresses one of the questions from the audience around, is the Vail Health community model reproducible to other rural communities? And Michelle, maybe you could comment on that and see if any other panelists want to tag on. But Michelle.
Yeah, great. Thanks, John. And I definitely applaud the work that Will and Vale Health have been able to do. It's pretty amazing. And I know there's many innovative ideas out in our rural communities and stuff, but we do lack the capital in most cases to be able to do that. And I think that's where it's just so helpful to have the recognition from the state and the federal level that really innovation dollars and stimulus dollars are needed in our rural communities to be able to make these transformations, so that way we can continue to meet local needs and have our patients stay in the local area. You know, the best solutions really come from each of our rural communities to try to meet those needs. We just need some infusion of cash to do that.
Thank you. Anyone else want to tag on? I have a question I'll go to here from a CEO of a rural hospital in Lincoln, Colorado. It's kind of an insurance question, but let's see what the panelists have to say about one of the biggest challenges we face in rural frontier healthcare is the barriers insurance companies place on providing care locally. What is being done to encourage insurance companies to allow more care to be provided locally rather than forcing referrals to an urban provider? And anyone can comment. Maybe Mike Conway could answer that later on for Kevin Stansbury about that one. How is Nancy? You came off mute.
Sure, I would just say briefly, I would agree that Commissioner Conway, I think, can speak more broadly to this about private insurance, but I would say that Kevin Stansbury's question goes right toward our support that HCPF wants to lend as well toward centers of excellence models where we really are, incentivizing and providing the funding so that the services as well as the revenue can stay local. That's better for the patient when that capacity is available there, and better for the community.
Great. Thank you.
And John,
yeah.
if I could add on to that as well, I think in addition to what Nancy mentioned, relaxation of regulations that allow us to do what's needed to be done in rural communities. So for example, in a place like Lincoln at Kevin's hospital, if you have a nursing home and a rural health clinic and a hospital all attached together, why the heck can't we have a staffing model that allows it to exist as a system to be able to do that? Right now, there's also a relaxation of regulations at the federal level for Medicare around telehealth for certified rural health clinics, and that ends when the pandemic ends. And so we need a relaxation to continue on those telehealth efforts to be able to provide those out. So those are just a couple of examples of, I think, ways that we can work together as both state and federal to enable our rural communities to better serve their needs.
Exactly. And, we're 10 days into a Medicaid expansion of a substance use disorder inpatient benefit. Wouldn't that be a possibility too for some of these facilities to cater to that benefit?
Yeah, absolutely. I think there's so many creative, innovative ideas that can come out, but again, we just need some money to be able to enable those.
Thank you. Maybe one, maybe two more questions, but here's an interesting one about the implications of expanding the criteria for designation of rural hospitals as critical access hospitals, which have a special federal criteria with reimbursement from Medicare. Is there any interest or barriers to expanding that designation? Anyone care to take that?
Right now, there's barriers at the federal level to offering that expansion out right now. So there needs to be legislation that's created that would allow a rural hospital to convert to critical access should that better meet their community needs. There's also barriers, I would say, for critical access hospitals to transform as well, should they not want to maintain the full critical access hospital within their community and have something like a 24/7 ER with a clinic attached to that as well has come up as possibilities, but neither one of those things can take place right now because they require federal regulation changes.
Thank you. And then there was a mention in the questions about the Hill-Burton Act, which is 70-year-old federal legislation that created a lot of our critical access hospitals, 25 beds or less. In the 50s, and a delivery stay was 7 to 14 days, and healthcare has changed in the 70 years since the bill passed. And I think there was some suggestion that maybe it's time for some new federal legislation to help some of these facilities serve not only the community's needs, but also address 21st century healthcare. That was a good point made there. But DJ, I think we're about at our time. I want to thank the panelists for a great and engaging commentary on rural health and rural hospitals in Colorado. So DJ, I'm going to turn it back to you, and thank you, panelists.